well, we might make a start then. Thank you, everybody, for joining us today for what we hope will be a very interesting session on preventative eye health with Professor Mingguang He and hopefully Professor Andrew Wilson, and I'll explain in a moment about that. This is our second in our series of Healthiest You series, which is a partnership between Australia-China Business Council, Swiss Wellness and the Australia-China Health Accelerator. And we're aiming this to help our members and friends to stay healthy, happy, and as we transit the stage 4 restrictions and come out happily the other end. Today we have two world-leading health professionals with us. Professor Mingguang He is a professor of ophthalmologic epidemiology at the University of Melbourne and a global expert on vision-related clinical and epidemiological research. Ming will speak about eye health and will be sharing some of his work on a landmark study into short-sightedness in young adults in South and Southeast Asia. Professor Andrew Wilson, we hope, will be joining us shortly. He fills numerous high-level roles, amongst them cardiologist at St Vincent's Melbourne Health Centre and the Chief Medical Officer for Safer Care Victoria, as well as an academic appointment at the University of Melbourne, where he leads an active clinical research program supervising research students and fellows. Andrew is also chair of the Australia-China Health Accelerator, and I'm delighted Jason Sun, the CEO of ACHA, is also joining this session. Ming, Andrew, Jason and I sit on the board of the Australia-China Health Accelerator, and it's always inspiring to hear about the important work the three of you are doing. Supporting today's events is Swiss Wellness, and I'm so pleased to welcome Justin Howden, our terrific supporter. He's the Head of Government Relations, Public Policy, Scientific Development and Community Engagement, and he'll say a few words in a moment. Before I hand over to Justin, I'd just like to remind you that this event is being recorded and it will include a Q&A portion with our speakers. Please direct any questions you have to the bottom of the screen in the Q&A section. So without further ado, over to you, Justin.
Thanks so much, Virginia. Swiss is really pleased to support this Healthiest You series. Thanks again for the opportunity to be a sponsor and supporter. This year, World Sight Day is held on Thursday, 8th of October 2020. It's an annual event. It's always held on the second Thursday of October, and it aims to draw attention to a range of issues surrounding blindness and visual impairment. It's seen as one of the most important communication and advocacy events about eye health on the global health calendar each year. Its key aims are for World Sight Day to raise public awareness of the key issues around visual impairment and blindness, obviously advocacy and influencing governments, in particular health ministers, to participate in and donate funds to research in this area. As a business, Swiss is all about healthier lifestyle choices through your nutrition, movement and mindset, which is that is a preventive health choice. Just some stats on eye health. In 2017-18, long-term vision disorders affected 93% of people aged 55 and over. There's currently 410,000 Australians, 1.7% of the population, with cataracts. 243 have macular degeneration. Interestingly, females experienced a higher prevalence of long-term vision disorders than males by quite a statistically significant proportion, 59% to 51%. And at the moment, over 13 million Australians, which is 55% of the population, have one or more long-term vision disorders. So this is obviously a major health area. So again, Virginia, thank you so much for the opportunity to support this series. And we look forward to hearing from the speakers today and from the listeners or viewers in the Q&A. Thanks, Virginia.
Thanks, Justin. That's terrific. Thank you very much for those interesting statistics. We were hoping that Dr. Andrew Wilson would be joining us. I know he is involved in the inquiry at the moment, so he may have had a little difficulty getting away. So we may start with Professor Mingguang He. Oh, here we go. Here's Andrew. Thank you very much for zooming in. He's just connected to the audio now. We know you're on a very tight time frame, Andrew, so thank you very, very much for joining us. I'll just introduce you now. Andrew Wilson is the Chief Medical Officer in Victoria, amongst other key roles. We're privileged to have him with us today, as he's obviously deeply involved with the current COVID-19 crisis. We understand you need to depart shortly, so I warmly welcome you and thank you again for your time, Andrew.
Thanks, Virginia. Thanks, everyone, for inviting me, and thanks for you all making the time to attend this seminar and during this really challenging time for us all. Just like to commend the team particularly, and as you probably know, we've been working together for quite a long time to foster healthcare relationships and lever opportunities for our community and work on things that we can share together as groups. I've developed some cultural and intellectual exchange. Obviously, it's challenging at this time to do it, and I think we're all aware that we're going to have to be with this virus and its effects for at least 6 months or longer. It's going to be part of our lives and how we do business and how we work together. So I think one of the things to think about is, and I know Ming and his team, and you're going to hear from him shortly, is two things I think we should think about in terms of preventive care and particularly eye health, is that as there's such an intense focus on COVID-19 and its effects on people and reducing the infections we have in our community, one of the things we've already seen, and we've collected a lot of data on this, is the impacts it has on everybody else's healthcare. So not just the economic impacts, of course, but people are unable to get to hospital to have their routine testing or testing particularly for cancer, but also for things like eye checks and eye care. So I think one of the things to think about for us all is how do we integrate the care that people need for a range of conditions in an environment where the system is so targeted to responding to COVID-19 infections. And although that's been seen in other countries, I think we now have data in Australia to show the really significant impact, the drop-off in attendance to GPs, for example, which last time in March and April dropped off about 30%, and then that cascaded over into the other parts of healthcare. So I think really trying to understand that and respond to that's a really key part of our response to the COVID-19 outbreak. And I definitely push that a lot in all the discussions. I mean, obviously in the last couple of weeks, things have become very intense, but we have been planning and working with people, and we definitely need to factor in eye care as part of that. And I think the other thing for us all to think about is what's the pathway forward from this. That clearly we're in a crisis response situation at the moment and have been for the last couple of weeks at least. But if things move in the direction that we're all expecting and hoping that they will, we're going to get back to a time when we need to start mapping how we move forward. And so it's worth spending time, particularly for areas that are not directly involved in COVID-19 response, to use that time to actually work together to map out what the health system looks like for them and their patients, and how that works interacting with that COVID-19 background that we get to pretty quickly. But I think understanding the impact on everyone's healthcare, but also thinking about ways to map forward as quickly as we can so that when we do get into a maintenance phase, we're able to catch up. So we need to catch up on all the care people have been missing out on, and how do we do that? What does it look like? And talk about those things like the role of telehealth and other things. So there are reforms that have been built in as a crisis response that many of us really are pushing to continue with the things that have worked really well. So there's opportunity for, after the bushfire of what we're facing at the moment, to have some shoots coming through. And actually now's a good chance for us to make sure that happens as well as it can, understand what's happening at the moment to our patients, and then reform the system in a way that, responds to that the best way we can. So I'm sure hopefully some of those themes will come up for you in the discussions today.
That's terrific, Andrew. Thank you very much for sharing that, and good luck with all the work. And we certainly look forward to working with you through the ACHA to make the most of all those opportunities that will be arising. So the very best of luck to you. If you need to go, please do. If you're able to stay for a moment, please also do stay. Absolutely delightful now to welcome Professor Mingguang He. Ming has carried out landmark research developing diagnostic tools and works extensively between Australia and China, sharing the best of both medical knowledge on ophthalmology and artificial intelligence. He's opened pathways for more collaborative opportunities for solutions that would never have been possible before. Ming undertook his medical training in China and the US and holds a master's degree in public health from Johns Hopkins University in Baltimore and a PhD in ophthalmology from Moorfields Eye Hospital in London. He's published more than 150 papers in international peer-reviewed journals, has presented more than 30 invited lectures at international conferences, and serves as an editorial board member for a number of international ophthalmologic journals. It's also a delight to work with you, Ming, which we do extensively through the Health Accelerator. So without further ado, Ming, I'm delighted to ask you to now present. Thank you.
So thank you so much, Virginia. I think, first of all, I would like to thank the ACBC and also Swiss for organizing such a great seminar or webinar, 1 hour. But then what I try to do in this around 20 minutes, I try to lead you through a little bit what myopia control means and how to control myopia, in particular in the context of this COVID-19 stage 4 lockdown, and where there are a lot of schools actually they closed down and the students really have to stay home and depends on this online education that heavily actually rely on the use of digital devices. So just tell you a little bit who I am. I worked in China for many years, 20 years, before I joined the faculty in Melbourne unit. I worked in Guangzhou for a major eye hospital called Zhongshan Ophthalmic Center. So I was the professor in that eye center and also Sun Yat-sen University. So a lot of research, the research program I'm going to mention today, actually they are the research projects that we carry out or conducted in China, but then I will also share with you a little bit of research in Australia as well. So in 2015, I joined the faculty by invitation from University of Melbourne as a professor, they call it Research Excellence Melbourne Accelerator Professor, RAM program. I'm a principal investigator in Centre of Eye Research Australia, and also director for WHO Collaborating Center. And one of the major scope of work for this WHO World Health Organization Collaborating Center is on preventing and controlling myopia. I'm also an ophthalmologist of evidence registered in RANSCO, so I also have my private practice in Melbourne as well. So going back to what is the myopia? So myopia actually is quite simple. So for objects, if the in this parallel light or parallel light under we call it without accommodation status. So this object will focus right on the retina. This is normal vision. But nearsightedness is when this focus is really in front of the retina. In front of the retina, this is myopia. So what are the changes of myopia? So why this object fixate or focus is in front of a retina? So actually it's because of the eye get elongated. So this is a normal eye. The focus is right on the retina. But if you got a myopia eye, your eye basically get a bit longer than normal. So we call it elongation. So in this situation, the light actually focus in front of the retina. So if myopia develop further, so further elongation will happen, and this will create a high myopia. For a lot of moderate or low or mild or moderate myopia, it's just a matter of like wearing a spectacle, a pair of spectacles. But once you develop a high myopia, this will create detrimental effect or damage on the retina, because the retina and the choroid, or this we call it the fundus, got extremely ischemic it's like no blood, the blood vessel is not good enough. So it will develop a lot of retina changes over time. So for example, macular hemorrhage, or even develop atrophy. If normally this problem happen in a high myopia eye. So this problem, remember, if you got a mild and moderate myopia, a pair of spectacles will solve the problem. Then you'll be able to see. But if you have a high myopia with this retina damage, even with the spectacle, you won't be able to see. We call this irreversible blindness or irreversible visual impairment. So it really requires treatment, and some of the this damage is not treatable. So for myopia control, there's two key things. One is to prevent the onset of myopia. We try to prevent a children or a child develop myopia from ametropia from normal to myopia. So this is called prevention. So for those already developed myopia, those key things control the progression. We don't want you to from -1 and progress to -8. So because that will create or increase your odds to develop all this retina damage. So the key thing for the children who with established myopia is to slow down the progression and then prevent high myopia at adulthood, which means we try to prevent the child develop high myopia when they reach 18 years old, so that we can prevent and avoid all this retina damage on the fundus of the eye. So as I mentioned, high myopia will lead to blindness. So there's a lot of population-based or evidence suggests that in developing countries like India and China or many other developing countries, cataract is the #1 principal reason or cause for blindness. But then in the developed country, developed region, or even in the Asia population, for example, in Singapore, this myopia actually rank as either the first, the #1 or #3 cause for this irreversible blindness. So we can see the high myopia in Asia population is really a huge problem. It has become a major or important cause for this irreversible blindness. So 17 years ago, we start our myopia research from population-based survey. Which actually, this is a multi-country study. We recruit 7 to 15 years old children from South Africa, India, Chile, Malaysia, and China. So this is a global study again. We use a uniform methodology. Everybody the same definition, same examination. What we discover, interestingly, is that in the children aged 15 years old, basically it's a junior high school graduate, the prevalence of myopia in the Chinese children has been reaching 80%, 80%, but in Malaysia a bit lower. But then in South Africa, African children actually got much, much lower prevalence of myopia. So myopia doesn't seem to be a problem in South Africa or African children, but it's a big problem in Chinese children and also ex-Asia population. So myopia it has been a long time that myopia prevention and control be neglected by the society, by the medical people, medicine, because they think, oh, myopia is a small problem. It's just a matter of like wearing a pair of glasses. It's not a big issue. But then in 2015, the Nature, this famous journal, published editorial. They got a feature article. They call myopia boom, like a boom. It's really an epidemic. So what they, in this editorial, what they really point out is that the prevalence of myopia actually significantly increased in Hong Kong, Taiwan, Singapore, and South Korea. From 1950, everybody got very similar, very low in the 20 years old, 20%, 30%. This is similar to what we found in Australia population. But then it gradually or dramatically, not gradually, dramatically increased over time. From 1970 to 2010, it increased dramatically to 80%. So among these people, like we call it young adults, 20 years old, in this ex-Asia population, and including Chinese urban children, they already reach getting to 80%. So this is a big problem. So in order to understand why the myopia develop more frequently in Chinese people, Chinese children, whether this is genetic because it's Chinese, and also, or whether this is really a schooling intensity problem, we run a 10-year study. This is a Guangzhou twin eye study. We did this study in Guangzhou. We actually enrolled the kids like 2006 and followed them annually until 2017. This is really a 11 years old, 11 years study, very long study. So if you can look at one of the typical change on children, so actually myopia again is a progressive disease. So 6 years old, start from epitropia, normal, +1, and then they progress all the way to -6. So this is one of the twin, and they're called twin. So you can see the progression rate is quite different. So then we plot this 10 years data together. And then if you look at the cluster, this, in terms of the degree of progression, like from 2 diopters to -4. -4 is like really a moderate myopia. We can put these kids into 3 clusters. One is those kids tend to be stable, they're normal all the way, like from the first to the 7 years, they're very stable. Another one is they stabilize, they progress significantly. So this we call it acceleration of progression. This is called stabilization of progression, and this is called late onset progression. So what we found is that this accelerated or very progressive children, this cluster is associated with near work activity. I'll tell you what near work activity really means later. And also if they have a parental myopia, if you have your parents are both, for example, both of them are myopia or one of them they're myopia. So this is the other risk factors for acceleration of the progression, like significant progressive myopia. But if you got a very stable progression on a myopia, so for example, low progression, remain ametropia or normal all the time. So this is associated with increased outdoor time. So if you spend a little bit more outdoor time, that your myopia or your refraction tend to be stabilized. So then there are late onset myopia for if you develop a myopia a bit later. So somebody developed myopia 7 years old, but then you develop myopia at 11 years old. This is also associated with increased outdoor time. So what we identify as a risk factor is really 3 things. One is near work activity. Second one is parental myopia. And the third thing is increased outdoor time. So going back to the risk factors, so what is the really important determinants for myopia progression and development? So we actually try to, if you compare a countrywide myopia prevalence data, and by stratify this population-based prevalence data into different type of education program. So for example, in Eskimos and Nepal, there's no formal education program there. So the myopia prevalence can be really, really low. But then in limited education system like urban India and Durban in South Africa, the prevalence is only around 10% among those like 15 years old. But then in a modern Western education like Sydney, Chile, North Island, Poland, the prevalence is a bit like double, like to about 20% or 30%. But then once this is again once this teaching or education style changed to X-Asia style, we call it X-Asia. A lot of pressure, for example, a lot of pressure, and then a very strict university entry exam is adopted, and the education environment is very competitive. In this environment or this country, like Beijing, Shandong, the prevalence of myopia is 80%. So this is clearly illustrate that the myopia prevalence in the country-specific myopia prevalence is really associated with the type of education system in your country or in your community. Then why this education is associated with myopia? So probably education is really a surrogate for near work activity. So some of the researcher in Singapore, they actually found out that if you read more than 2 books per week, then you tend to have a higher degree of myopia for the children. And another quite famous study conducted in Sydney, because Sydney myopia study proved that if the children read continuously, non-stop, or at a closer distance, then they are more tend to be more myopic. And the ORIDA study in U.S. population, U.S. children, they found out there were weak but significant effect on increased hours of near work. So what near work really means is, for example, reading and writing. So this is a very close-up distance to very close-up distance for the activity, basically. And second type of near work is a video or computer hours. And the third one is watching TV. So when an epidemiologist or public health people try to calculate the intensity of near work activity, they use the term called diopter hours. So they weight, if you got reading and writing, because it's so close up, they got 3. This is a weight factor. So this is most important. And the second important one is a video and computer hours, because it's a bit like not as close as reading and writing, but then just a little bit far from the activity, for the activity. But if you watch TV, because the distance is much greater, so they got a weight factor 1. 3, 2, 1. So then by looking at the diopter hours definition, you understand how this near work activity really impact your odds or chance to develop myopia. But then parental myopia is also one of the key determinants. So this is a study try to understand if you have both parents normal, one of the parents got myopia, and both parents got myopia. And then the prevalence of myopia in children, junior high graduate, it increased from 70% to 83% and all the way to 90%. So it proved that if you have more number of myopic parents, so the chance of myopia is significantly increased. So it's not just it's just a matter of like whether your parents got myopia, yes or no, but also is associated with the severity of myopia in the parents. So if you got both parents no myopia, and then increase from mild myopia, moderate myopia, severe myopia in the parents, so this chance of getting myopia in their children increased dramatically from 50% to 86%, and the chance of having high myopia increased from almost 1.4% is almost nothing. But then if you got one of your parents got severe myopia, the chance of their children have high myopia is increased to around 20%. So this parental myopia is a very important risk factor. So in another word, if for the child with both parents or one of the parents with severe myopia, they have a very high chance to develop a high myopia in the future in adulthood. So then we understand this risk factor a bit better than before. We understand this education does matter, and then near work activity and parental myopia. Can we create some intervention program to change or reduce the myopia prevalence? The answer is yes. For example, this is New South Wales news. You can see primary school allow parents to permanently excuse children from homework. You can request, my child doesn't, they don't have to do homework. This is feasible in New South Wales system, or again, this modern Western education system. But then in China, this is not feasible. This is one of the classroom where the children or students prepare for the university entering exam. You can see a lot of people under significant, we call it schooling intensity or pressure. And then if you tell parents, or we want to propose reduce homework or to reduce schooling intensity, the parent will always say, no, we want my kids into the best university in China. So this is not possible in terms of changing the education system. But do we have other strategy to prevent myopia? The answer is yes. So this is outdoor activity, as I mentioned, is a protective factor. So this is a very classical figure from Sydney myopia study. So if you classify these kids into outdoor, like from low intensity to high dose of high outdoor time, so this is a near work, high to low. So if you just look at the near work, this even for the children with very high level of near work, if they got sufficient level, high level of outdoor time, you can see the odds to develop myopia is actually less than 1.0. That means they're protective. So they have almost no chance, no odds to develop myopia. So the key message is myopia doesn't really matter, or even if you read a lot, it doesn't really matter if you have sufficient amount of outdoor time. But in this kind of analysis, we're not quite sure whether it's because more outdoor time associated with next myopia. Is it a causal effect? In other words, maybe the myopic kids stay because they wear glasses, so that's why they're not convenient for outdoor sport activity. So that's why we observe this association. So the most convincing method is to run a clinical trial. So in China, actually, we run a clinical trial in 6 years old primary school. It's like 12 school they enroll. We randomize some of the school into intervention and some on the control. And then what we change, what we implement as an intervention is actually quite simple. We will add one outdoor class, 40 minutes only, daily, every day. We add 40 minutes outdoor activity into the school. So in 3 years' time, we proved that the incidence of myopia reduced from 40% to 30%. This, we're talking about 20% relative reduction of the myopia instance. So this paper was published in JAMA in 2015 to become a very strong evidence to suggest or propose outdoor time or additional outdoor time will be an effective intervention strategy for controlling myopia. And then we change our, I can translate our idea into more treatment method. So we actually, from this outdoor time clinical trial, we actually create, we call it sunlight classroom, then so that we can increase the time exposed to sunlight. But then this, and then we proved that in this sunlight classroom actually reduce the incidence of myopia as well. But then it's so very expensive, because if you build a classroom like this, then in order to prevent warm house effect, and then you have to a lot of electricity, a lot of cooling system to make it feasible. But then we also create a localized. We just create this light therapy on the eye locally, and then this is, we call it direct retina light therapy on retina. So this has become a new treatment for myopia control. We actually have a patent on this. And then what interestingly, if you use the device like this to create a local retina illumination, it actually reverses your myopia. So it actually, if you look at the axial lens changes, in 1 month time, the eye getting shorter, so reverse myopia, and then control 96% of the axial lens elongation in the myopia children, and then also 100% control on this psychopedic reflection, I mean myopia progression. So this is an important message. Light exposure to people's retina, it will reduce or control the myopia progression. So there actually are a couple of methods. It's for the kids which, if we've established myopia, it can be medication, medical treatment, optical treatment, and other method. So the most popular medication is no-dose atropine, eye drops basically every day. It doesn't create a side effect, but most of time, but it can control myopia. But then also autokeratology, Ortho-K is a very popular for both correction of myopia and also control of progression. So this is evidence from Singapore study. Actually, what they prove is that this is a control. If you have atropine, low dose atropine, you got much better what they call endpoints in terms of myopia control. So in comparing in comparison with high dose atropine. So 0.01% is better. 0.05% is more effective. And then this is similar study in Hong Kong proved that 0.05% is better. So then people translate this this eye drop into commercial product. So this is a commercial product created by Singapore National Eye Center. So that they got it myoping, and then again is what I mentioned before, optical, ortho-K, and other contact lens, and also MyoSmart, MyoKicks, that many spectacle, special design spectacle. The product aims to control myopia progression. They normally gain 50% of the control efficacy. So in China, actually, there's one company, they licensed the myoping from Singapore, and then they develop a new eye drops. And then this eye drop will make this, enable this company, their share actually price triple in 20 days, become a very popular share in in China. But then in opposite, Tencent has been a lot of revenue from Tencent from computer gaming, like this digital game. But then when the government allows official control on the, they call it digital screen time, then Tencent's the share price evaporate 30%. So for your family, if you have a child with myopia, so what I recommend is to draw myopia graphics. So this is one of the case one of my patient I saw in China. So she developed myopia in 6 years old, but then over time we start the atropine treatment. You can see this very significant progression. In 1 year time, they progressed 3 diopters. So from -1 to -4 in only 1 year. Then we start atropine, high dose atropine treatment. You can see the progression is really arrested. So there's now we go to now we're going to discuss what this digital screen time really means to your kids, your children. This is a very big study conducted in US. They enroll 40,000 kids aged 2 to 7 years old. But what they prove is that if they call this moderate screen time or digital screen time usage, 4 hours a day, to me is a lot, but then they say this is moderate. This moderate or higher, they screen time use is associated with lower psychological well-being, lower self-control, more distractibility, inability to finish tasks. So psychologically, if the kids spend more time on the screen or digital screen, is not a good thing for psychology and well-being. But then in a COVID-19 scenario, all the kids, they have to stay home, and then they have to spend more time. They have to rely on screen, and then actually it increased the. At the same time, because you have to do this online education, you have to use the digital screen time. So what is the recommendation? So WHO guideline actually, if for the kids 1 to 5 years old, they recommend less than 1 hour screen time. But then there's also a 30-10 principle, rest for 10 minutes after 30 to 40 minutes of educational screen time. But then it's important for parents to supervise the digital content so that they can, your child or your children can focus the digital time to spend on more learning than gaming. But then you better have a daily schedule planning so that you understand from what time to what time and where the digital device can be used. And then the parents should act as a role model. If you want a child don't pay that much digital device or gaming, you should reduce your own dependence on digital device use as well. So, and also you try to engage children offline play. Even in this busy online education scenario. But then most importantly, spend more time outdoors is the key to prevent myopia progression, at least 2 to 3 hours per day when safe and legally allowed. So the take-home message is increased outdoor time has been confirmed as the only modifiable risk factors. So additional 40 to 60 minutes time increased outdoor time can reduce myopia onset by 20% already. And then we should try to implement this 30-10 principle, rest 10 minutes for every 30-40 minutes real work activity. And then you got to manage your screen time. And then most importantly, if in a family, a child in a family with both parents or one of the parents with severe myopia, they are greatest risk. So they should be, the parents should be aware of this situation and then should pay attention to myopia control. Mm. So at the end of the presentation, this is really the Brian Holden is the most successful optometrist in Australia. He invented a hydrogel silicone contact lens. This is a daily job contact lens that he is able to generate 30 million licensing income every year for around 15 years now. So he's an inventor. But from this, he also gave a lot of funding support for our research. In this perspective, you can see myopia control is a very big market, but then also a lot of children will benefit from myopia control, and then they have a better well-being in adulthood. Thank you.
Mm. I mean, that's absolutely fascinating. A little bit scary too when you think of the amount of time we're actually forced to spend on the screens just to get our work done under this current working from home situation. I'm just, to start off the questions, and I do encourage everyone to type in as many questions as you'd like to ask while we have this opportunity. But I'm just wondering if there's a best light that we can work in, while we're on screens. Is there a better form of light that we should be, like illuminating our rooms with?
Yeah, people are actually spending a lot of time and money trying to understand how to increase. Number one is to increase the illuminance, like because normally in the bedroom the illuminance is about 500 lux. So people try to increase the illuminance by 2,000 lux, but this is too bright for reading. Secondly, people try to change the spectrum, so they try to simulate the sunlight, they call it light spectrum distribution, so they can simulate all these light wavelength spectrum very similar to sunlight. This kind of research is ongoing, but the key message is that you should bring your kid outdoor if allowed. Otherwise, it would be very helpful. You just even sit right beside your window, open your, use the sunlight from your window is also effective.
Mm-hmm. And for me, I mean, as someone who wears, glasses, I wear them all the time, and these go dark when I go outside, so they are a sun glass as well. That is obviously stopping the light getting into the lens. I mean, should you just walk around for a while without glasses on, or does the good light still come through?
The good practice is under the sun or go outside, but with sufficient protection. So for kids, in particular Caucasian kid, you should wear a cap so that then you can also the sun cream, so then you can protect big skin cancer, the chance of skin cancer and so on. So outside, but with sufficient protection. Very important.
So I've got a couple of questions here. One of them is, how much does the blue light damage our eyesight? Do you think the anti-blue light glasses or screen protectors work?
The blue light concept is actually, at least at the moment, there's no sufficient scientific evidence. Anti-blue light design is really is a way to protect the blue light exposure on the macula, but because by natural, all this blue light has been screened or absorbed in your lens and cornea, so the blue light that can really reach the retina or the macula is very minimal. So at the moment, a lot of scientists believe anti-blue light glasses or this strategy is really a business concept rather than clinically useful.
Scientific. That's interesting. And then just another question here is, how can adults and office workers protect their eyes best?
For adult is different because it's we call it computer, because for adult, the myopia already won't progress anymore. So it's more like, we call it computer fatigue syndrome. So because when you use your computer, you try to blink less. So this blink less will create dry eye problem. A lot of people, if you use 4 or 5 hours computer, then you feel your eye very dry because you don't blink it properly. So again, this is all more like a fatigue issue. So the useful advice will be probably just 30-10 principle. If you don't do too much continuously, but then you're going to have a break after 30 minutes or 1 hour.
And eye drops, you know, those sorts of things to lubricate the eyes. Does that help, or is it still better to take a break?
Yeah, because most of these the computer fatigue syndrome is because of the dry eye. So of course, the lubricant eye drop will be helpful.
This is like a personal consultation. This is thank you. Certainly got dry eyes. Another one is a question here from Eddie Zhao. Is laser surgery recommended for short-sightedness?
Yeah, it depends on the scenario. Most of the time, the laser treatment, it doesn't control myopia progression, but it's just like it changed the diopters of the cornea. So most of this time, laser treatment is considered only when the kids' myopia, they got stabilized. For example, after 18 years old, the myopia won't progress anymore. So probably then we can consider laser treatment. But then for clinicians, they have to assess your cornea thickness and this and that, because not all people eligible for laser treatment. So they have to go through this clinical consultation.
Quite complicated. I'm wondering now whether Justin or Jason have any questions they'd like to ask of Ming. Justin, did you have any?
Yeah, thanks, Virginia.
Yeah.
I'd be very interested in the professor's thoughts on further research that could be undertaken, or what projects he might recommend we should be looking at for public health and public eye health. Professor, I'm just interested in your comments on what you think the next research project should be, please.
I think it depends on the target disease. If for myopia, so we have been working on some myopia control devices. But then for other well-being, for example, to prevent age-related macular degeneration prevention. So people are working on nutrition supplement. Many of these studies are ongoing and try to prove that whether this daily nutrition supplement is able to prevent the onset of dry or wet age-related macular degeneration.
That's very interesting. And that's where Swiss can jump in there, Justin. That sounds like an
Virginia.
opportunity.
We'll see. But there's also, as part of the lifestyle choices as well, it's not just nutrition. Obviously, that could possibly have an impact. We don't know yet. But there's also the choices we make to adhere to those good practices that the professor's talking about, which is easy to say and hard to do sometimes. 30 minutes on the screen, 5 minutes off, or 45 minutes on, 15 minutes off. It's having to dial in those choices that we all have to make, which is very difficult as well.
That's
Changing people's behavior is quite challenging.
It's true. Ming, I know you've done some terrific, and this is going slightly off the topic, but I know you've done some terrific research in relation to eye diseases, and you have developed a free app which you've made available for particularly Indigenous areas for diagnostics. I just wondered if you wanted to just very briefly tell our audience about that, because it's quite a fascinating work you've done.
Thank you, Virginia. Actually, we developed, we call it automatic fundus camera. So because in the indigenous population or regional people, like remote area, so the challenge is the accessibility to eye professional, to optometrists, to ophthalmologists, because this kind of service is not available. So what we do is we integrate artificial intelligence with fundus camera. So this system is able to screen people without requiring even a technician who can operate, because it's a fully automated system. So we didn't depends on a technician to operate, to take the fundus photo, but then it doesn't depend on the the accessibility to access to eye professional like optometrists. We don't require optometrists and the presence of optometrists and ophthalmologists. So we are running a program on this, and then we try to enable, we call it robotic service in the remote and indigenous population. Actually, we received a lot of research grant support from MIFF and the Commonwealth government to enable such a service as they call it innovative solution for eye care provision.
It's terrific, because that can then be a first diagnostic step before they then need to go and see a health professional, so it can be delivered in remote areas easily. So that's terrific.
Because at the moment you have to send an ophthalmologist examine and screen all these people and identify patient potentially can benefit from cataract surgery and make a list. And then on the second visit, you send another ophthalmologist. Very time consuming. With our device, we can screen 100 people in one day, and then we just automatically, prepare a list of people who potentially can benefit from cataract surgery. And then ophthalmologists can come in and do the surgery.
Well, that's good. So apart from your obviously skills in designing that, the artificial intelligence side of it gives those algorithms and the research which can then base the diagnostic. So that's fascinating. Great use of AI. Jason, I wondered if you were wanting to ask any questions or make any comments.
Yeah, sure. Professor He, thanks very much for your presentation. I'm aware that in Australia, preventable eye disease is becoming an issue as the population ages. There's a couple of diseases in particular has increasing prevalence. One is glaucoma. And the glaucoma is being very much underdiagnosed by optometrists at the moment. Can you just share with the audience what's the signs and symptoms of signs of glaucoma they should watch out for, and the research you're working on to help optometrists in diagnose glaucoma?
Glaucoma, actually the prevalence, it doesn't increase over time in Australia. But the real challenge for glaucoma management is they call it undiagnosed glaucoma. So among, for example, in Australia, even Australia is very well developed healthcare system. Among 100 glaucoma patients, only 50 of them, only half of them got diagnosis previously. So the challenge is because glaucoma is an asymptomatic disease. So for most of the glaucoma patients, in particular open-angle glaucoma patient, they are not aware of the existence of the disease because it's asymptomatic. It doesn't affect their vision at all at the early phase of the disease. But then when they develop some vision problem, they're already in late phase, because glaucoma is irreversible. If you got damage, then you can't go back to normal. So a lot of patients, they show up in your clinic already at the late phase of glaucoma. So for glaucoma, the solution is to more glaucoma screening. So that's why we also use the artificial intelligence system. We deploy this AI system in the general practice clinic, because we just did a simple survey. We understand that 80% of the Australia people, 80%, they see the GP at least once in the previous 1 year. In the previous 12 months, at least 80% of the Australian people actually they have some experience to see their GP. So we use this as an opportunity to screen for eye diseases. Just put a simple device there, then they can test their fundus and then screen for glaucoma.
That's amazing. I do have another question here from one of our attendees. They would like to know the connections between nutrition and eye health, such as taking vitamins, all that sort of thing. So could you comment on that?
Yeah, first of all, I'm not an expert on this area, but then there's a couple of they call it AREDS study running in US. So they kind of prove that this they call it multiple vitamin or nutrition supplement. It will improve the visual acuity, but then with a marginal benefit. It's not a lot, but then you have to continue use it for a long period of time, and then you see the effect.
So of all the things that we can do to help, it's that outdoor health or careful exposure to the sun is the best that we can do. Even as an adult, that will be helpful. Yeah.
Correct.
Oh, that's great. I think that's all the questions we've had in now. If anyone has another one, please do type in quickly. Jason, I just wondered if you wanted to do any sort of closing remarks for us today.
Yeah, thanks for and also Justin for sponsoring the session, and obviously our speakers, Professor He and Professor Andrew Wilson. Professor He has given obviously a very detailed introduction in eye health, but Professor Andrew Wilson also being responsible for the COVID-19 response and graciously shared his time with us. So I represent an organization, Australian China Health Accelerator. We are a non-for-profit organization, and we have an independent board. Both Professor Wilson and Professor He and Virginia are on our board, as so myself. So our aim is to facilitate collaboration between Australia and China in developing a better health system to benefit the population. As you can see from Professor He's presentation, Professor He has the benefit for collaboration in research for both countries. Obviously, this research access to large patient size and particularly identical twins, it's very difficult to achieve in Australia. So having just this very simple example shows you how important it is for international collaboration in medical research and benefit both populations. So we do like to see such health collaborations continue, and particularly in this difficult, challenging health global pandemic time. And I like to just use to close that health and science knows no borders, and certainly it's having a particular country first strategy is not going to work in this health pandemic. Thank you. Thank you.
Thanks, Jason. That's terrific. And Ming, again, thank you so much for your time and sharing this wonderful information with us. To Andrew, also in his absence, and Justin, thank you very much for your support. It's been terrifically interesting. Just about to come onto your screen, I hope, will be a closing slide, just to let you know that our final session in the series will be coming up with Professor Kylie O'Brien, who'll be speaking on a holistic approach to health. She's going to focus on botanicals and herbals, and also her key area of expertise, which is traditional Chinese medicine. So we hope we'll see you on the 8th of September. Details on how to book will be sent to you following this event. So in the meantime, stay well, stay happy, and reach out to us if we can be of any assistance as we all hopefully travel very safely through this current stage 4 lockdown. We look forward to seeing you again soon. So thank you once again. Farewell.
Thank you. Get some sunlight.
True. Bye.
Bye.